think that's about normal for this time. So welcome back, everybody. Thanks for joining at a new time. I hope that for those who could get away yesterday, actually got some time off and were able to get a little bit of relaxation in. And for those not, welcome back. Several things have come up in the last couple of days. So we're going to try to get through lots of different tidbits. Hopefully it won't take the full time, and then we'll see if there's other questions. So just kind of interesting tidbits. We have surpassed the 400,000 deaths mark in the US, unfortunately. That's the sad news. We are still seeing increasing rates of infection in certain pockets, although we are seeing plateaus in many areas of the country. Interesting note about the mortality. So just looking, and granted, this only applies to the time from where we had COVID in Monroe County. But if we go back to March, we've had a death about every 67 seconds in the US since that time. So that's very sad and distressing, to say the least. As far as COVID rates of infection, the places where it is still rampant, the highest rates of infection, surprisingly, are in Hawaii right now, followed by Illinois, Indiana, and West Virginia. Now, the interesting thing is Hawaii was one of the states that was relatively calm for a while. Now they seem to be having a fairly rampant rate of infection. The place in the country that has the highest percentage of infection, so 1 in 7 citizens of the state of, anybody that's infected? North Dakota. North Dakota is the worst place in the union to have lived currently. They are also the best state in the country if you want to get a vaccine. So they have vaccinated 65%, or have used well over 65% of their vaccine. They surged ahead of West Virginia as the best states for vaccination. West Virginia is just shy of 65% of vaccine used as of today. So if you need one vaccine, those are the 2 states to hang out. Interesting thing about those 2 states, what makes them different? Number one, neither of those 2 states have, well, first, they included the general population in their equivalent to our phase 1A. So while we were all vaccinating healthcare workers, they were vaccinating healthcare workers and over 75 in North Dakota and over 80 in West Virginia. So they got started on the general population faster. Number 2, both of those states, pharmacies are generally not owned by large corporations. So in West Virginia, they specifically requested that their vaccine went to 290 different pharmacy groups across the state. And the pharmacies used their own database of patients to start administering the vaccine faster, and it allowed for a wider rollout. In North Dakota has a law where a pharmacy has to be owned by a pharmacist. So there are only 5 CVS pharmacies in the state. So even the pharmacies took over vaccinating the nursing home and nursing home workers. So both of those states are different than every other state in the country where a certain percentage of the vaccine went to pharmacies who went about, yeah, of course, Jenny Radcliffe. The one time Jenny Radcliffe wants to talk in the middle of the COVID pandemic is to say something about pharmacists, of course. The one time pharmacists do something. Basically, the interesting thing seems to be for those who got vaccine out to the pharmacies from the very beginning, they actually did better. And earlier inclusion of the general population. Just for ducks, New York is 27th ranked across the country as far as rate of vaccine usage. So not doing great at this moment. The worst states in the country are Alabama, Georgia, and Arkansas. Arkansas has only used 14% of the vaccine that has come their way thus far. That's pretty horrible, to say the least. So interesting bits, the vaccine allocation is going to shift. So it's going to shift based on usage and then also based on population density. So we're going to see some changes in vaccine distribution even in the days ahead. But certainly the rate of usage will not help New York dramatically because we're about square in the center of the nation as far as vaccine utilization rates right now, although certainly there is a state mandate to try to push vaccine use pretty heavily. So that's the interesting bit of knowledge. So follow up on that. So North Dakota, 1 out of 7 North Dakotans have been infected with COVID. If you compare that to Monroe County, it's 1 in 17 who have contracted COVID. The best place in the country to be is Vermont, where they are 1 in 61 folks who have been infected. So just gives you a sense of the disparity. And then other tidbit, which somehow passed me, which I usually like COVID tidbits. As of November 18th, there is no county in the United States that has not had at least one person infected with COVID. So there's no place in the country that you can go and not have a COVID case have occurred there. That county happened to be Loving County in Texas, which only has 148 residents, but 3 of them all decided to get COVID on the same day. So there you go. That's how they finished with a bang. So that's where we stand currently. You can see that the percent positive locally has started to drop off. We've seen this pretty much across the board, as you'll see in a minute, as we get to the regional statistics. We are seeing lower rates of hospitalization, or at least lower occupancy in the hospital. ICU occupancy still remains relatively high. Our flurry of mortality seems to have slowed a bit, although there is still a projection that we likely still have another week and a half where we may still see, relatively high rates of mortality comparatively, as we still have relatively high ICU occupancy. But on the whole, when we looked at the projections from the CTSI folks who have been modeling this, not only has our worst case model now flattened dramatically, but it is pretty clear that we are on the downward side of the plateau and likely should see some stabilization here over the next couple of weeks if all continues on the current course. Fortunate for those in the sports world, but not in the COVID world, the Bills continue to do well. So there will likely still be Bills viewing parties in our future. And so we'll have to see how that contributes. But that has become an ongoing discussion in the scientific lexicon now, which is somewhat humorous. So that's where we stand at the moment. So certainly places that things are still not great. But on the whole, we are not seeing that rapid rate of rise that we were through the holidays, and potentially even got out of the post-New Year's window a little better off than what the projection suggested we would. So that is definitely good news. The graphics, I'm not sure there's anything terribly exciting other than you can see that hospitalized rate on the bottom right there. We have definitely plateaued and are on the way down, which is good. You can see the gray, which is the mortality, is still on a climb. We may still see that for another week and a half, but the rate of rise is not quite as fast over the last couple of days in particular. And then if you look at the percent positive, as we've talked about before, which is the next graphic, you can kind of get the sense of the Richter scale effect, but it definitely seems to be slowing from that dramatic shift up that we saw previously. Going to the region, similar kind of process. Everybody kind of plateaued and is now on their way down, which is good. So we still continue to hear of outbreaks. Unfortunately, several of the outbreaks that we've heard seem to be small clusters, 10 or less people that seem to center around funerals, unfortunately. And unfortunately, a lot of those are people who died of COVID that then the mourners who come to pay their respects at the funeral becomes a mini super spreader event. But we are definitely seeing across the region things heading down in the right direction. The testing of type of COVID coming. So that's a good question. I'll pause and take that one. So we continue to check for COVID variants. There's now reports of yet an additional COVID variant that has been noticed in Europe. Europe has taken a stance across much of the European Union of closing schools because of the rate of spread that they've seen with the variant that is now pretty rampant. We continue to see a fairly small penetration of the variant to date. However, the estimates continue to be that by March, these variants will be the prime source of infection. So one of the big discussions is to try to get ahead with the vaccine so that the vaccine helps outpace the variant by the time March comes. Right now, we're losing that race, obviously. But fortunately, locally, the testing for the variant continues. However, it is a fairly specialized test, so it's not something that's being done locally. It's only being done at the state lab right now. So I don't know of any modality at the moment that will determine variant or not. And largely, other than just the rate of infection, it doesn't change anything about your isolation needs, about your ability to get the vaccine, any of those other things. So it probably only matters in the sense of just understanding what the rate of spread will be, because we do know that the variant has a much faster rate of spread than the standard COVID virus at the moment. Okay, so continuing on, that leads into testing. There's already been some question in the chat that I answered earlier about the turnaround time. In general, the total volume of testing is low. Now, some of that is due to the fact that the ambulatory surgical centers have either paused, or certainly the owned by the health system have closed entirely for the moment. So that has decreased the drain on testing that was coming from pre-procedural testing. But even amongst those presenting with illness, it has diminished a bit. So because of that, the turnaround time for testing has improved. So the quoted time is still within 36 hours or 36 to 48. But my understanding is most of the tests are coming back in 24 to 36. Largely depends just on the time of day that the test was acquired and where it was acquired and how long it takes to get back to central lab. But my understanding is those tests are coming back in a fairly timely manner. And with the 2 new platforms going live in a couple weeks that are high volume, rapid turnaround, that should continue to be good, even if the volume of testing goes up. So that's good. A couple of the questions I got over the weekend that I wanted to jump over to for just a second. So as far as if you had COVID and or got vaccine, and then you are exposed to COVID again, do you have to quarantine? So this has actually come up a lot. Folks have begun to ask. Right now, the guidelines have not changed. So I verified over at the end of the week, I think it was. And right now, there has been no change to the recommendation that even if you've had COVID or if you've gotten the vaccine, you still have to go through the same rigmarole as everyone else. There has been some discussion that, the CDC says there's at least a 90-day window. There's been 2 articles in Science that have come out. One that was at the end of December that said that folks who got infected had at least a 5-month window. There's been a subsequent article that came out last week that we discussed that said you have an 8-month window where you seem to have adequate antibody response. We know that the vaccine seems to have probably about the same timeline, maybe as much as 9 to 12 months of protection with the 2 vaccine modalities that are out currently. They likely will update that recommendation as far as quarantining soon, but as of yet, that has not changed. So for the moment, same rules as everybody else. There are no changes in the guidelines about exposure and need to quarantine after vaccination or after COVID infection. So I wanted to cover that. I think that was the big question that came up about testing. So I'll leave the rest of them for now. Another point that came up, and actually our Kick Butt Pharmacy team has put together some pointers. There's been a lot of questions about allergy and risk of the vaccine and what would necessitate evaluation by the allergy immunology folks and what would preclude someone from being able to actually receive the current vaccines that are on the market. So this comes from Erica Dobson and her pharmacy team. So I'm just going to share this. I'm reading verbatim. So per the CDC and FDA emergency use authorization guidance, if a patient has ever had anaphylaxis to either polyethylene glycol or polysorbate, they should not get the mRNA vaccine. Those are the only 2 absolute exclusions. So other severe allergic reactions, eggs, foods, pets, venom, environmental latex, does not preclude anyone from receiving the vaccine. So they should be observed for a longer period of time. Currently, the observation period is 15 minutes. The recommendation that was shared was that they should be observed at the healthcare facility for at least 30 minutes after they get the vaccine, and they should alert the staff at the vaccine site that they do have these allergies, just so that they're aware and can watch them. But as of right now, there are no other absolute contraindications. There have been several discussions about the benefit or need to pre-medicate with Benadryl and or Claritin prior to coming. I certainly don't think that's a terrible idea if someone has a history of severe allergies, but unless you have anaphylactic reaction to polyethylene glycol or polysorbate, there are no absolute exclusions at this moment. So just wanted to share that as well, and we'll make sure to put that in the email today that we share with you also. So that's that little bit of good news. So now the big discussion, vaccine availability. At a time where we want to be pushing vaccine as fast as we possibly can, it is in the shortest possible supply. So normally New York State gets about 300,000 doses of vaccine. There had been a lot of hope, as many of you probably heard, that with the federal government saying they were going to push out second doses to get that volume, keep out the strategic reserve to get it in the hands of vaccinators. Turns out that they had already released that strategic reserve. So whether you interpret that as a misunderstanding or a falsehood may depend on which side of the aisle that you sit, but nonetheless, there is no magical cadre of vaccine that is going to suddenly start flooding the market here anytime soon. This week in particular, compared to the 300,000 doses New York has typically gotten, there's only 250,000 doses that are coming into the state. And with the plan to disseminate those to pharmacies and the state and health department pods, there are more mouths to feed and less vaccine coming in. So this week is going to be pretty thin. Many of you have reached out because you have staff members that have had second thoughts that are in the 1A category. You've had staff members who were under their COVID exclusionary period that now are out and therefore candidates for the vaccine. You've had staff members who just didn't get it before and now want to schedule an appointment. As of right this moment, there are no other appointments to be had. We just don't have any new vaccine, and most of the vaccine that's coming in is going to be going to second doses, at least for this week. The links that we had shared with you all before for the U of R clinics to get vaccinated, those were taken down, as I believe we shared last week, because they got shared so widely in so many different places that all kinds of folks were logging in and scheduling appointments, and it was causing all kinds of havoc as far as whether these people were even cleared to get vaccinated at this moment. So those links are now inactivated. They are going to be creating new links that they will be sharing with us. But at the moment, there's no vaccine. So we don't have vaccine to administer. So it'll probably be next week at the earliest based on current timelines that we see. So we'll share more with you as that comes, but at least I know there are several folks who are kind of itching and want to get the vaccine or have staff that are, and that's the timeline that we can anticipate for right now. Regionally, what we're seeing here is pretty much true across the entire Finger Lakes region. So as a hub, our vaccine allocation has been a little bit thin, I would say, based upon our rate of utilization of the vaccine. Even though New York State has only administered about 40% of the vaccine that had been distributed to them as of January 15th. In the hub, we had administered somewhere on north of 72%. So the Finger Lakes region has actually done fairly well. But because of that, we are pretty much running out of vaccine every day. So we're burning the amount of vaccine we have pretty much as soon as it comes in the door at the moment. So we'll see where that goes. There has been a lot of chatter and a lot of questions about the Johnson & Johnson vaccine. So I think it was Friday that Johnson & Johnson released in New England Journal the results of their phase 1 and 2 trials. So the good news about that, at 29 days post-vaccination, 90% had a significant and adequate antibody response. That's good. At day 57 post-vaccination, 100% had achieved adequate antibody response. So just as good or better, depending on how you look at it, maybe not quite as fast as what we saw with Pfizer and Moderna. The benefits, it's a one-dose vaccine. So that obviously has some advantage. It has immeasurable shelf life as far as stability and storage capability. So that's better. The downside is that while there has been a lot of press that Johnson & Johnson is going to go to the FDA for emergency use authorization as of February 1st. It was clarified on Friday afternoon, at least that I saw it, by their chief medical officer, that they anticipate their phase 3 to be complete. They've enrolled. They've anticipate their culmination of the data to be complete in February. It sounds like by mid-February, they will likely go to the FDA. However, the chief medical officer did share that their production capacity is about 2 months behind schedule. So the initial promise was that the US government had purchased 100 million doses of the Johnson & Johnson or Janssen vaccine, depending on, there are two companies, one's distributing, one's producing. So that 100 million is true. It was 100 million contingent upon obtaining the emergency use authorization. What Johnson & Johnson had committed to is that upon approval, they would have 12 million doses available for release. So that would have meant 12 million additional doses would have flooded the market sometime in February. Now that has been pushed back until April, and their plan had been to deliver all 100 million doses by June. That's still not going to help us a lot. So by April is when we anticipate the AstraZeneca vaccine to potentially have hit its mark and for them to be ready to approach the FDA for EUA. So largely, unless something dramatic changes, we are not anticipating any new vaccines hitting the market other than Moderna and Pfizer for the next couple of months. That's a lot of words in a short period of time. So for right now, the wait for a different type of vaccine, people who are suspect about the mRNA vaccine, number one, the data does not support that. Number two, there's going to be no other vaccine hitting the market anytime soon. Number three, I do not see anything that's going to change the availability of Pfizer and Moderna in the short term. There have been a lot of whispers about Biden tomorrow releasing the executive order to invoke the Defense Production Act, which may allow them to produce the vaccine in other venues. While I am really hoping that is true, I can't remember if it was the Operation Warp Speed folks or someone basically said that this is not just a turnkey kind of thing. You can't just hand the blueprint to someone and expect them to start churning out vaccine, that it takes quite a bit of time. So I'm hopeful that that may not be 100% true, but I'm not sure that that's going to be the solution at the moment. So long story short, while there are more and more venues for places where you can receive the vaccine, it does not change the amount of vaccine that's hitting the market. That leads into the next discussion. So there were a flurry of emails and phone calls and discussions of where can I get this person or my dad or somebody that I like or somebody that I don't like, where should I tell them not to go to get the vaccine as quickly as possible. So the governor announced, or the Finger Lakes Hub announced, that there were 12 Rite Aids that were going to administer the vaccine, each which would have 100 to 200 doses for their first clinic. So that everybody can do math as well as I can. That means at best, there were going to be 2,400 doses of vaccine that were going to be administered by Rite Aid. Within 7 minutes of the link going live, there were 4,714 people in line to schedule those appointments. So there were at least 2 people for every vaccine that was available. We knew that there weren't going to be 2,400 to begin with. The county and state pods, on Friday, the links to the state pod went live. Friday morning at about 8:00:01, you could have gotten a vaccine as early as probably Thursday. At 8:07, the site crashed because all the vaccine appointments had been taken. 4 more times throughout the course of the day, they loaded more appointments, and promptly those appointments were gobbled up. So there will be more, but at the moment, all of those additional sites are pretty much getting gobbled as fast as they come live. Good news is there's a lot of people who want the vaccine. The bad news is we just don't have more vaccine hitting the market in the short term. So we'll continue to try to keep folks abreast of this. Friday, as fast as I could find the new honey hole of where to get the vaccine, it was gone. So several of you reached out. I would share a link and you would email me back 2 seconds later and tell me that it was closed or it was not working. It wasn't because I was toying with you or trying to be evil. It was just happening that fast. It was absolutely ridiculous as to how quick the word got out on this. There'll be more, but right now we're just kind of going through the motions and trying to get as much information about when more vaccine will come available. Next week probably will be a little bit better. But again, the state won't find out until Thursday. The state won't tell us until Sunday. And then we won't expect to receive the vaccine until Tuesday, Wednesday of next week. So between now and a week from today, pretty much what I've just said is going to be what carries us through the next 7 days, because there'll be no other additional vaccine hitting the region. Okay, so that's pretty much what I got. All of this is going to be skewed completely tomorrow. So the word on the street is that Biden has somewhere between 60 and 100 executive orders that they are lining up to try to determine in what order he's going to put them out. Are they all going to go on day one, and what they're going to mean for the greater good? I have no idea what our call on Thursday is going to entail, but it's going to be fun. So needless to say, our not scheduling on Wednesday is probably a good thing, because it's probably going to take us a couple hours at least to sort through all those puppies and figure out what the hell is going on in the world anymore. So I would say everybody kick back and enjoy, because everything we just talked about for the last 42 minutes may be a complete wash come this time 48 hours from now. But it's going to be enjoyable. So with that, I think I've run my list. So LJ, I'm sure there's all kinds of
there's always fun things, but just really 2 resources to highlight for our teams. One is we spoke about last week that as the county health departments are having trouble keeping up with contact tracing and quarantine guidance, that our practitioners are getting called more and more on what to do. And so for those of you who participated in the last Schools and Healthcare Forum last month, we did a little blurb about contact tracing and quarantine. It takes a village. We've just taken that piece that was part of a larger FAQ document, and we've consolidated that. It is on our website. It will go out today with a link in the emailing, and basically just reviews again the definitions of close contact, isolation, quarantine, just as a review, so that you can share that with your staff who maybe are on phones. And just to clarify that the only thing in that guidance that has changed at this point, again, is that the quarantine timeline is 10 days versus 14 days. That being said, we're getting a number of phone calls and emails from many of you saying that you're hearing from patients who've gotten some advice that doesn't sound like it's in keeping with the guidance. There's not a lot of this, but there's a few. I've been in contact with our Monroe County Department of Public Health, and I'm definitely hearing from them that there are many, many, many new hires to the teams of people who are doing this contact tracing, both at the state level, because some of this gets done through a state site, and also at the county, and certainly at outlying counties. So I just wanted to say with you, we got that piece of information for you to look at. If you are identifying significant irregularities, it is fine for us to, for you to email us on that. If you can clarify the county, that's what I'm realizing is the big thing. Because a lot of times I start to go down a pathway and then find out, oh, that's not Monroe County, that's Ontario County. So if you can identify the county that's involved, the county health department teams appreciate that. They're trying to make sure that everyone is giving the appropriate and correct guidance. And then the second, change of topic, but second resource available, I mentioned on our call last week when I reviewed the updated return to exercise guidance for pediatric patients, reminding you again, this does apply according to the AHP's updated clarifications. It applies to children K through 12. It applies to PE as well as sports, whether it's scholastic sports or sports in the community. And the goal is for these kids to get, as they have been getting from you all, an in-person evaluation, if at all possible, and assessment. So we put out the updated algorithm last week, along with the tiny revision to the assessment and release document that you all have. And again, the only revision to that was that A moderate risk category is defined by 4 days of significant systemic symptoms, not 5. But now what we have for you, which I think will really be helpful to folks, is a FAQ that was developed in partnership with our pediatric cardiology team. So I'm just going to highlight this really quickly. The 2 key questions that I think will be relevant to our providers are, what are concerning pre-existing cardiac conditions that should automatically require cardiology referral after a child or adolescent is released from isolation, having had COVID-19 infection? So just really quick, the things that are automatic, basically, patients who are already followed by cardiology for significant heart defects or disease, especially those patients usually are seen frequently by their cardiologist, at least every year or more frequently. It includes patients, obviously, also with acquired heart disease or complex congenital heart disease who are on medications or oxygen. And usually these patients may already have some activity restrictions as indicated in their cardiology notes. What about pre-existing cardiac conditions that really don't warrant an EKG or referral, as long as you're not identifying any symptoms that would be concerning post-COVID? So the cardiology teams have highlighted there are many minor cardiac conditions that do not need to trigger an automatic referral or EKG. This includes those patients who are seen very infrequently. There's greater than a year between their visits. They're on no cardiac meds, and they don't have any activity restrictions in place. So this includes things like small atrial or ventricular septal defects, or PDAs, repaired ASDs, VSDs, PDAs, or other lesions that have no significant residual lesions, things like mitral valve prolapse, vasovagal syncope, and many arrhythmias. And if any of these conditions obviously are present and a patient does have concerning cardiac symptoms, obviously those are the kids you refer. And then one other little thing about EKG findings, because I'm hearing back from a lot of you about worries about you're getting EKG findings, particularly on some of the college students or the older adolescents that are not being reviewed by pediatric cardiology. So they note that minor EKG findings such as sinus arrhythmia, obviously, left or right axis deviation, an incomplete right bundle branch block, or possible LVH hypertrophy would not need urgent referral. But if there's any questions on those, they are encouraging you to give a call to pediatric cardiology to help sort that out. So that document will go out today. Just wanted to make sure people knew that. These are many of the questions that you guys have been sending kind of one at a time, and that I think have been asked of the peds cardiology nurses who are reviewing these cases for triage. It's not designed to make cardiology less accessible to you, but hopefully it'll answer some of the common questions. And that's it for me. Chad, you got anything else?
No, I tried to answer a couple questions in chat. Renee, did you have anything?
Only to remind folks that will be our next call will be on Thursday, not tomorrow, but you did mention that already, Chad, so good job.
I got lucky on one. All right. I do not have anything else in the chat. I will point out, so just to Kathleen Hoven's question, which I answered in the chat about folks who are homebound because of quarantine but need important labs drawn for whatever reason. This is a tough one, and we've definitely run into this in several cases. And unfortunately, the home care systems across the region have been very strapped because of quarantine and staff infection rates and what have you. Your Med Home Care is no different. I will say the report from Your Med Home Care is that things have gotten slightly better. So they're trying to be more responsive, but they're still stretched extraordinarily thin. So I definitely would not use it for anything that could be even quasi delayed. But if it is absolutely critical, I would reach out to the home care agencies to see if they could do it. Another question that came up, I think this came up last week, was for homebound patients, when and if their age group or criteria are allowed for vaccination. Do we have any plans for how we would reach out to get those folks vaccinated? So the easy answer to the question was, off the top of my head, no. But after a few brief discussions, we actually got some volunteers of emergency medicine faculty and staff who were willing to go out and in partnership with the EMS services actually do homebound vaccinations. So that discussion is already underway. The problem is we just don't have enough vaccine. So when and if the vaccine starts to meet the availability of need, hopefully if the gods are with us next week, we may be able to come up with a fairly quick intervention to reach out to those folks. Obviously, that goes without saying, this can't just be folks who, hey, it'd be easier to not have to go in, or I can't get an appointment the standard way, so can we get one of those EMS vaccination appointments? It won't be quite that user-friendly, but for those who are truly, truly homebound, we may have a solution that we can interdigitate. So more to come on that as well. I can ask if they're really giddy about that homebound lab draw, but I don't want to cash all the political chits in right out of the gate, but I realize those things are important. So I'm happy to have that conversation. Your question about the internet access, that's key. So I will say, there's two flavors. So at least for the health systems, they are reaching out to the patient via phone. So that is one modality. Now, I realize the next question is, what if they don't have a phone? What if my 100-year-old grandfather can't hear the phone? What do we do then? You're right. There's not a great solution for everybody at this moment. It's certainly not 100% foolproof. There are some that are, we're getting pretty close, I would say. But I think we're going to have to take stock of who we missed at some point and what the next best option is. To some degree, it's how do we vaccinate the most as fast as we possibly can. And, with, like I said, with 4,800 people lining up for 2,000 or less doses just in the community pharmacies, at this moment, there's still plenty of arms that are popping up with a moment's notice. So hopefully we will see that start to ebb a little bit here in the coming days and weeks, but it's going to take time, no doubt about it. Another chat that just came up. Guys,
I think I can take
good.
that one. Like, good. So the question is providing guidance regarding the recommendation of testing patients 7 days after they've been in contact with a COVID positive family member. So essentially it's the really close contacts, family contacts, and the county's recommendation that those close contacts, asymptomatic close contacts, get tested around 7 days, and that some families are refusing. The only thing that you can do in that situation, my understanding is they're doing that in order to hopefully catch some asymptomatic COVID positive people that might be within that family before they actually get released from their quarantine, at the 10-day mark. So two things would be just to emphasize to the family that that individual who's not getting tested, even if they got tested, still needs to quarantine for 10 days. But if it's a young child or if it's a family situation where they couldn't break contact, meaning they're not all masked in the house, the person who's got COVID isn't separated from the rest of the family, the person who's got COVID is not making meals for the rest of the family, et cetera, that quarantine goes for longer. That is a really important thing. There's that whole issue, if you can't break contact, the quarantine starts again, essentially, when the contact, when the case gets removed from isolation, because then your 10-day period starts further. So you could seriously have families with children in quarantine for 20 days, which sounds just awful to me. So the other advantage of the test is if that person, if that child ends up being positive, then they're just, they're kind of in an isolation mode at that point. It could be shorter than ultimately prolonged quarantine. That made sense. It made sense in my head. I've looked at it 100 times. So if that did make sense, no mandate that they have to, there's no mandate that those families have to.
That sounds good. I agree. Everything she said. Any other questions? I think we've run the chat room list, and for once I have a couple minutes to spare. All right, seeing none, hearing none. All right, so we will get back together in 48 hours. The whole world's going to change in the next 24, so it'll be fun and new and exciting. But we'll try to keep up with all the information we can, and then we'll start over again on Monday, Wednesday, starting next week is the plan for now. So,
Here's hoping it's a little less exciting.
different kind of exciting, maybe good exciting. We'll We'll shoot for something good for once. All right, guys. Thanks so much. We'll see you guys in 48 hours. Take care.
Thank you.